Welcome everyone today. We're very pleased to have you with us to allow us to present a very timely and I hope an exciting lecture for you all on a very interesting topic that's gained a lot of attention around the world and in recent literature. And it's an interesting title, Preventing the Emergency Among the Emergencies, Utilizing Topical Wound Oxygen to Lessen Hospital Admissions and Amputations. I'm Dr. Robert Frykberg from Phoenix, Arizona, currently in Dubai, where I'm coming to you from. And I'm very pleased to introduce today's speaker, Dr. Chris Bromley, who's the Chief of Foot and Ankle Surgery at Vascular Hospital in Poughkeepsie, New York, and an adjunct faculty member of the Kent State School of Podiatric Medicine. Dr. Bromley is a popular speaker in our meetings. He's well accomplished, broad degree of experience. And Chris, I'd like to turn the meeting over to you, and we all look forward to seeing what you have to say about this new and exciting topic. Chris. Dr. Bromley, it's all yours.
Thank you, Bob. And again, thank you to Present for making this happen. And thank you to all of you to spending time with us today. As we move forward in the presentation, just a little business disclosures for myself and Dr. Frykberg. I currently have no financial conflicts, and Dr. Frykberg has a research grant for AOTI and is also a consultant, and you'll see later in the presentation is involved as one of the principal investigators of the literature that we'll review. Again, you're all muted. Please feel free during the presentation to submit questions on the board. Those questions will be read aloud by Dr. Frykberg at the end, and we'll get to as many of those as time allows. Objectives. So this is a CME presentation. So the learning objectives today are to describe the elevated risks that wound care patients are experiencing during the COVID-19 shutdown. We will discuss the evidence supporting the utility of topical oxygen in wound healing and safely done at home. And then we'll discuss the clinical benefits of cyclical pressure topical oxygen therapy that can provide for our patients. And obviously, we've all been affected by COVID, and the patients that we treat are more at risk. So we'll kind of get into that. So this is a slide that I really like, and I credit the author below, but we have all of these factors that are involved in our diabetic wound patients, and now we have the COVID isolation. So our patients have been sequestered at home. They've not been active. They probably, like many of us, have been eating and for comfort and gaining weight and being less active. As we've heard before, sitting is the new smoking. So our patients have been sitting and have not been seeking health care. So all of these myriad of factors that we know so well that complicate the treatment of diabetic wounds are going to be worse now because our patients have been home and very sedentary, not seeing their doctors, not managing their diabetes, and not getting appropriate wound care. So the consequences of COVID-19 on our wound patients are significant. And due to the fact that many of our patients have multiple comorbidities, they are at increased risk of complications as a result of COVID-19, and we must really look for those. We talk a lot about the cytokine storm and the inflammation and the inflammatory response, and we'll kind of dive into the vascular complications of that. But one of the biggest complications is the fact that there's been a 40%, and I think this is an underestimate, a 40% decrease in wound care center visits in the weeks 12 through 14 of early 2020 compared to 2019. So these patients are not coming out, they're not attending the wound care centers, they're not coming to our practice. I know from my own practice, we normally see 40, 50 patients a day. I was seeing 2 or 3 patients a day. So these patients were not coming in and obviously not getting better. So as a result of that, we as providers should expect that there's going to be a disruptive effect of this pandemic on the healthcare system for the next year and a half. I have patients of my own that are afraid to have surgery because they're told they have to have a COVID test. So patients are still very much afraid to come to our offices. They're very afraid to go to the wound care center. They're afraid to attend the emergency room. So when we look in the past, we can see when there's been lack of access to healthcare and lack of access to providers, this increases the emergency room visits, hospitalizations, amputation, and negative outcomes. While the risks of individual patients we've kind of covered, the risk now is compounded because the entire system is affected. We're all affected. Our hospitals are affected. We're going to start to see the sequelae of that as we move forward. So, you know, we would be remiss if we didn't just review educationally. What are the normal burdens of chronic ulcers? According to the ADA, over 9.5 million Americans suffer with chronic ulceration. The prevalence of foot ulcer has not changed. In fact, it's gotten worse because we're seeing more and more diabetics. Our patients are more sedentary, they're more obese, and as many as 24% of these foot ulcerations result in amputation. The mortality has gotten worse. The mortality has doubled from 20 to 50% in the first 3 years and 70% after 5 years. This is a profound psychological impact on our patients who are suffering from chronic wounds. Everybody's been very lonely. They've been separated from their active social lives. They've become more depressed. They're, as I said, more sedentary. And that whole psychosocial stress is really going to decrease the outcomes and increase complications, not just for our patients, but for everybody. You know, we're all under the same level of stress. This has been a very difficult time for all of us, and we really want to take great care of our patients. But we also have to remember to take care of ourselves. So this is this comes from ADA, Diabetes Care. This is looking at diabetic foot problems during COVID-19 pandemic in a tertiary care center. So again, this is the emergency among the emergencies. So when we look at this, there's been a threefold increase in amputations associated with diabetic foot ulcers to those patients who are admitted during COVID-19. The high risk of amputation is seen in COVID-19 because of the lockdown, because these patients have not had proper care, therefore their outcomes are worse. And I think that we would be remiss in, remembering the cytokine storm. So whenever we have patients with this much inflammation, this much of a cytokine response to the infection, we have to always think about clotting, because clotting is obviously a big factor, and I think it's underappreciated, and we see that reported in the literature as recently as this month. Wound care during COVID-19. What is the new paradigm? Well, the new paradigm is think about your wound care center without walls. Think about virtual health. The strategy now is to think about how we can see our patients virtually, and we can work together to triage to our colleagues and work with our patients across the spectrum in healthcare. If you asked me this time last year or asked any of my patients if they wanted to do a telehealth visit, they probably would have shook their head and said no. So we've all had to get used to telehealth. Look at us, we're communicating virtually on a webinar versus being at a meeting. And we're going to think about wound care center without walls. I want you to think about expanding your practice. If you're not currently doing telehealth in your practice, please feel free to email me. I can give you some great resources about how to do that. Again, that's a whole nother lecture. We've done a webinar about that, and it's up on the Present website about virtual healthcare. So if you haven't seen that, please go ahead and take a look at that. So during the COVID crisis, we have to remember to triage and work with our colleagues. So this particular chart is based on the Infectious Disease Society of America, where we look at how do we strategize and how do we classify each of the diabetic foot infections that we have. So on the critical side, these are patients who have severe infections, they have gas gangrene, they may be at risk for sepsis, or they may have a clot. So these patients are all going to be triaged to our hospital. These are priority 1 patients. The next level in orange is the serious patients. Those patients have moderate diabetic infections. They may have chronic ischemia or dry gangrene. They may have osteomyelitis or cellulitis beyond 2 centimeters, worsening ulcer, maybe some tracking, maybe some gas, a flap that's not doing well. These patients can be managed outpatient. So we want to triage these patients with our colleagues. We're seeing them at the office. We can follow up with them virtually. We can use virtual health to consult with our interventionalists and our vascular specialists. We can use virtual health to work with our home health companies so that we're making sure that the home health nurse, the foot and ankle specialist, the vascular, everybody's on the same page. Next, we're in yellow. So we're looking at, these are guarded patients. These typically we're going to manage on our own. These are patients that have an ulcer that's getting better, that they've got, an exudate, the cellulitis is under control. These are patients that we'll typically see in our office, do the debridement, get them started, and then use telehealth to follow them at home with their family or with the home health specialist. Lastly, in green, these are the patients we don't really worry about. These are the patients that can be managed at home. This is an uncomplicated foot or leg ulcer, venous stasis ulcer. These are patients we're going to be managing at home. These might be the patients that once they're stable, we incorporate the topical oxygen as an alternative to where they would have been going to a wound care center or coming just to our practice. Again, think outside the box. Think about wound care center without walls. Think about how you can expand your practice to be able to manage these patients if they're going to be home and not able to get to you. So remembering that even though we're going to do this virtually, we wanted to make sure that we order the appropriate vascular testing. So on the arterial side, an ABI really isn't enough. The gold standard for looking at the PAD is that the oxygen level is more accurate. You could look at digital waveforms, but any of these patients that are diabetic, long-standing diabetics, they're going to have a false positive on the ABI and may even have a false positive on the digital waveform. So you want to really look for that transcutaneous oxygen level as the most accurate assessment at the digital level for arterial disease. On the venous side, that's the side that we really forget about, and that's a whole nother lecture about venous disease assessment. It's far more common than PAD. It's something that we really kind of overlook. We record in the chart the patient has some varicose veins, maybe some telangiectasias, and maybe some swelling. But really, we need to dive deeper on the venous side, understand the SEEP classification, which you can see in the diagram on your right that talks about the different stages of venous disease. And don't forget to order Doppler studies. 40% of DVTs are asymptomatic. So when you have a swollen leg and you're not sure, always order a duplex scan of that lower extremity. Look for DVTs, they're out there. And remember that the cytokine storm is a big part of the clotting factors that we see, and the morbidity, mortality of clotting is really understated at this point. So if you've got a patient who may have had COVID, they may have been better, you think that there might be something going on there, make sure that you look for those clots. Venous hypertension, something I like to talk about, that is that, it doesn't matter to me if the patient has a pulse. I mean, no pulse is not good, but if they've got a pulse, but they've got venous hypertension, because of the venous disease, the wound isn't going to be perfused. If the pulse will come down, it hits the capillary bed and gets stuck because it can't make the turn and go back. So the venous disease is really important to diagnose, assess, and treat. If you don't do that, you're not treating the wound. It's not just debriding and applying a great graft or applying topical oxygen. It's looking at the whole leg, the whole patient, and being able to assess what their disease needs. When we look at diabetic foot infections and diabetic foot ulcers, the pathophysiology is expansive. This is a great graphic. It talks about neuropathy, it talks about PAD, it talks about ulceration infection. One of the things that we forget to talk about is, when I was in school, we were trained to talk about sensory loss. Well, sensory loss is important because we lose that protective sense, but almost as important to me is the loss of the autonomic nervous system. The autonomic nervous system is what controls everything. It controls your plumbing on the arterial side. On the venous side, it controls the cellular response to what's happening at the diabetic foot and the foot ulcer. So remembering to assess for that. Once these protective layers have broken down, we get deep tissues, we get increased bacteria, we can have bacterial colonization, and these infections be very severe because, remember, our diabetics have impaired immune system, they have impaired response to the infection on the nervous system side, on the autonomic side. So this particular slide reminds us of how complicated these diabetic foot ulcers and infections are. As these infections get worse, the qualitative and quantitative aspects of infection is important to remember. Staph aureus and beta hemolytic strep are the first microorganisms to colonize, acutely infect skin once it breaks down. The chronic wound is typically more complex. It's polymicrobial. It includes gram-negative rods and anaerobes. So remember, the longer the patient's had this infection, the more complicated it is. You've got to start to think about anaerobes and make sure that you are treating the patient and you're covering yourself for those as well. So when we think about, we've already sort of touched on the bacteria, we talked about the arterial and the venous side. When we look at chronic wound cascade, one of the problems that we talk about is the lack of oxygen or hypoxia. Hypoxia occurs when all of these complications come together. If the patient has venous insufficiency, they're going to get a perivascular fibrosis. That's going to cause increased oncotic pressure, and that gas exchange isn't going to happen the way it should because the tissues are affected. When they have diabetes, obviously they have hyperglycemia. The hyperglycemia decreases nitric oxide. Again, another factor, as well as the other things that go into this. Patients who have hypertension or atherosclerosis or PAD, all of these things come together. We see that there is a decreased oxygenation, and in the decreased oxygen or the hypoxia is going to decrease wound healing. So when we talk about these patients, we have to do all the things that we do well, but we have to always think about oxygen to assist us in this journey. Well, this is a really interesting slide. This is in 2019. These three guys were all awarded the Nobel Prize for their research on how cells manage oxygen. And they've established this is the basis for how we understand. We knew about hyperbaric oxygen for many years. We knew oxygen was important. We knew that it was cytotoxic to bacteria, but we didn't really understand why. Well, their research in 2019, as I said, they were awarded the Nobel Prize, talks about hypoxia-inducible factors. When you have hypoxia, the hypoxia affects the factors that affect the cell function and affect the DNA of the cell and the overlying stimulation and the communication within the cell. So these very important understanding of how oxygen and hypoxia affects wounds. Tissue oxygen tension plays a critical role in combating these wound infections. So remember, as we mentioned, oxygen is cyclical to microorganisms that lack the defenses against oxidants. Hyperoxia and hyperbaric oxygen exert antimicrobial effects by increasing the intracellular flux and reactive oxygen species, ROS. In bacteria, certain species cause DNA strands to break when they're exposed, and degradation of RNA, and inhibition of amino acid biosynthesis, and inactivation of membrane transport proteins. So the oxygen is causing that bacterial cell to stop functioning. Oxygen tension is also effective in the activity of increasing our antimicrobial, so it makes our antibiotics more effective. Hyperoxia potentiates, while anabiosis decreases the activity of many antimicrobial drugs. So we have a wound like we talked about with an anaerobes. We want to make sure we get into our hypoxia situation so that we can make our antibiotics more effective. With regards to the host, hyperoxia elevates the oxygen tension in the infected tissue, which elevates facilitated oxygen-dependent killing leukocytes, again, making the patient's host immune system more effective. Prolonged hypoxia can inhibit DNA synthesis in lymphocytes and the generation of oxidative bursts in leukocytes and macrophages. So that's why patients will have 5 days of topical oxygen therapy, and then they have 2 rest days to allow the body to transition. So the broad role in oxygen in wound healing, again, remember whenever there's been an injury, if you see that on the far left-hand side, there's the first role of the body is hemostasis. There's some vasoconstriction and clotting, and the body starts to release the inflammatory mediators. Then we go to the inflammatory phase. The inflammatory phase is important, and again, oxygen is going to help this process. It's going to improve the immune response, the inflammatory mediators, the interleukins, cytokines, reactive oxygen species, neutrophils, macrophage, phagocytosis, and platelets will then secrete growth factors. Again, we can enhance this in our patients who are vascular compromised on the arterial, venous, or neuropathy. We can enhance this response by adding oxygen. Usually our diabetic wounds get stuck in this inflammatory phase and they really don't move forward. By using oxygen, you can help the wound and help the patient progress to that proliferative phase. Again, here's where we're looking for granulation, endothelial cells. Angiogenesis is important here. The VEGF is stimulated by that topical oxygen. Fibroblasts will form and we get collagen synthesis. Really important. This collagen is going to be key to the healing as well as the long-term outcome of this particular wound. Will they recur? And then we go into the maturation process where we have remodeling and epithelialization. Again, oxygen is involved in every one of these phases. Important to remember, so that oxygen is something that you're thinking about all the time whenever you have a wound. So what are the different types of oxygen and how can we influence that? So what therapies can correct oxygen balance? Contrasting hyperbaric oxygen, there's the chamber type, systemic hyperoxygen, where the patient comes to the wound care center, they're in either a group chamber or an individual chamber. You're going to systemically oxygenate the blood at 2 or 3 atmospheres. It requires a very expensive facility, it requires a lot of staff, and it requires the patient to go to the wound care center. And at the top of the talk, we talked about how the patients are going to the wound care center. So we have to think outside the box. So what other ways do you have to get oxygen to this wound? Well, topically. Topical oxygen can be administered to tissues at 1 atmosphere. There are portable devices that can be used at home. They're very inexpensive and they can deliver oxygen to the wound. You can be cyclical. You can adjust the moisture, and you don't have any of the systemic toxicity. You don't have the cost associated with the other modalities that we talked about when you have to use chambered HPO. So these are the different types of topical oxygen, and I have used all of them, as I'm sure Bob has. If you look at the smaller devices on the left side, those are no pressure, those are continuous diffusion. They typically use a small device to drive oxygen into the dressing. There have been studies, they're wearable, they're rechargeable, they are effective at pushing oxygen into the wound, but there's no humidity control, there's no compression. And again, the compression, we'll talk about why that's important. Then there are constant pressure devices. They basically go over the leg. They have a low oxygen flow, low pressure, and they don't do anything for the leg edema. As I said, there's no cyclical flow and there's no compression. The sort of state of the art is that cyclical pressure. So this varies between 10 and 50 millibars. The reason that's important, remember when we talked about PAD and venous disease, one of the things that happens in these legs is the leg gets full. There's poor flow on the arterial side, there's poor flow on the venous side. So when you use cyclical pressure alternating from 10 to 50, you're recreating that pumping effect. So the oxygen is really important, but the cyclical pressure, that change in pressure, stimulates the body to get that flow going, and it drives the arterial flow into the wound and the venous flow out. So that's really the secret to this, is that pulsatile cyclical pressure, and then you can also manage this with the moisture. You can manage the humidity in this type of wound so that you can stimulate the body to granulate faster. So let's talk about some evidence that supports topical oxygen combating wound infections and how you can treat your patients at home. So this is a slide that's talking about pressurized topical oxygen diffuses easily into a wound. So the question everyone has is, if we put a dressing on the leg, or in this case on this pig, and we put pressurized pulsed cyclical oxygen in there, what happens? So in this particular case, the studies with Fries et al. Basically put an O2 sensor 2 millimeters deep to the wound, and they pulsatile the flow of oxygen. And you can see, if you look at the graph, within a few minutes, you've doubled the oxygen in the wound based on the sensor. So very interesting evidence-based medicine. So what happens with pressurized topical oxygen in the wound? What happens? What happens is you're stimulating the VEGF in the wound. The VEGF will stimulate neovascularization. If you look at the control on the left, you can see very, very little vascular structures, very few vessels. When you look at the oxygen treated, you can see all these vessels, and that is huge. So this is a stained smooth muscle punch biopsy 7 days after being treated with oxygen. So exponential increase of that neovascularization. And without neovascularization, there's no healing. So what happens at the tissue level? Pressurized topical oxygen promotes stronger tissue and leads to less recurrence. So if you look at the control group, this is a hemolytic stain. You can see on both of the A and B control, there's very little collagen. The collagen is labeled G, and you can see it's very irregular and it's not organized and it's not very prevalent. This is in the control group, the reason why patients reulcerate. You got them to heal, but they reulcerated because they didn't heal properly and they didn't heal with the collagen that you need to hold the patient together. Look at the oxygen treated group. You can see in both those slides, labeled G, that there's a lot of collagen. And Fries et al. Really demonstrated how important it is to use oxygen, not only to get these wounds to heal, but also to get them to heal and stay healed long term. Again, remembering the role of oxygen healing, we have patients who have PAD, they have venous disease. So the PAD is going to decrease the oxygen because of decreased flow. Our job is to give the oxygen topically so that we can have the bactericidal, increase the VEGF, stimulate neovascularization, and to assist our antibiotics. Again, it's not enough just to breed it. It's not enough just to give the patient antibiotic. You got to do the debridement, the standard wound care, put them on the antibiotics, but give them the oxygen to make the whole process happen. Very important. Again, because we're going to get into a couple of studies to review the standard of care for the diabetic foot ulcer, offloading, which we know so well in podiatry, looking for infection, doing your biopsies to make sure there's no malignancy. If you've got a patient who has an ulcer, you've got to do your PAD studies, you've got to look at your venous studies, do good sharp debridement. We've got lots of great wound care products at our disposal, but they're no substitute to doing great sharp debridement and applying the appropriate wound care. There is, a diabetic foot recurrence rate of about 40% on ulcer once it's healed. So our job is to do the standard of care, but also get them healed, but try to prevent them from recurrence. And we just want to get away from using the word heal. There's in this particular quote in this paper, they talk about the critical aspect of diabetic foot disease, emphasizing when an ulcer heals, that the foot disease is considered not cured, but in remission. I think that's a term that we could use. Your ulceration is in remission, then the patients don't feel surprised if it comes back. So we have to maintain those offloading and protocols. So what are the benefits of oxygen wound healing? Just to review, there are different types. You can do hyperbaric in a chamber, or you can use local oxygen therapy. Oxygen is involved in the increased energy production in the reparative process, cell proliferation, collagen synthesis, reepithelialization. Again, furthermore, oxygen and oxygen-derived hydrogen peroxide stimulate the reactive oxygen species. The reactive oxygen species is important as a superoxide. It's bacterial toxic, and it also stimulates angiogenesis. For wounds, especially chronic wounds, the manifestation of reduced oxygen leads to impaired leukocyte and bactericidal activities and impaired wound healing. So overall, we're using oxygen with good wound care and managing the patient with antibiotics and the things that we do well. So what is cyclical pressure topical oxygen therapy? So the oxygen supplementation is going to be there to break you out of that stalled inflammatory process, upregulate the leukocytes, stimulate angiogenesis, and fuel collagen. The cyclical is non-contact, so it's not like a compression device. It's non-contact. It's basically alternating pressure. The alternating pressure will reduce edema, which is really important. Remember, if we've got edema, we've got a lot of that interstitial space fluid, which is preventing our body from changing gases in the capillary beds, preventing wound care. So the positive pressure promotes granulation and prevents and there's no risk of collapse and stimulates the healing. The humidification is important because we know that wounds won't heal in a desert. We need this to be humid but not wet. So let's dive into some of the studies, and obviously Dr. Frykberg is with us today, so he'll be able to comment. This is out of Diabetes Care. This is a multinational, multi-center, randomized, double-blind, placebo-controlled trial evaluation the efficacy of cyclical topical wound oxygen therapy in the treatment of chronic diabetic foot ulcers. And this is cyclical pressure topical wound oxygen therapy in diabetic foot. This is a landmark study. Obviously, the author number one you see on here. As we move forward, what is the study aim? The aim of the study is random clinical trial for non-healing diabetic foot ulcers to explore the efficacy of cyclical pressure topical wound oxygen in home care therapy in healing the diabetic foot that has been failed the best of standard of care. So there were 17 centers around the world. You can see them listed. The study design, all the patients met the stringent eligibility criteria. They were enrolled into a 2-week run-in for optimal standard of care, which included the gold standard of offloading, as we talked about, sharp debridement, and the wound therapy. Only the DFUs that were not on a proven healing trajectory, that would be less than 30% wound reduction, these were included. And then they were randomized into an active phase of the study. This is, again, a double-blind study where there's an active topical cyclical oxygen and the same device, but as a sham. And the investigators were double-blinded. So the therapy, the subjects admitted themselves the cyclical pressure topical oxygen at home, 90 minutes a day for 5 days a week. The subjects were visited weekly for sharp debridement and wound assessment, and this included digital wound pictures. And these pictures were analyzed by a blinded central assessor. So there's no influence here by the investigators. The results were, they were looking for what was the rate of complete wound healing at 12 weeks. And there, in the active cyclical pressure group, it was 41.7% compared to 13.5% in the sham group. So you can see that is a significant outcome. So the primary outcome is there was a 6-time more likely to heal in 12 weeks in the treated group than in the sham group. So if you look at the graph, you can see the blue line represents the standard of care plus the cyclical oxygen, and the yellow is the sham group. So significant improvement there. Not only did you have a 6-time more likely to heal in 12 weeks, but if you look at the long term is they did very well and stayed healed. So if you look at the graph on the left, this is the cyclical pressure topical oxygen therapy arm. You can see in all of the different centers involved, you can see that patients were all doing very, very well compared to the sham group. Look at the sham group. Everybody's all over the map here. And you can see that the reduction overall for the entire study was 64% versus 2%. There was a 2% increase actually in the sham group. So what happened long term? The durability of wound. Remember we talked about collagen. Oxygen helps with the collagen. The collagen is the key to preventing recurrence. And if we look at the study run out 12 months post-enrollment, there was a 6-time lower risk of recurrence in the treated active group with topical cyclical oxygen versus a 40% in the sham, which is very consistent with what we see in diabetic foot recurrence as well. Durability, again, this is another graphic showing you the proportion of ulcers closed. Look at the active group at 56% on the tall blue on the right, and versus the sham at 27%. So again, significant heal. So we're looking at 12 weeks. We had 41 versus 13. At 12 months, we got 56% versus 12%, 27% for the enrolled patients. So here's another study. This is looking at the technical and clinical outcomes of topical wound oxygen in comparison to conventional compression dressing. So remember we talked about venous disease. Venous ulcers are my least favorite thing to treat. And what is the gold standard for venous disease? Well, it's conventional compression dressing and incorporating pneumatic compression. Well, and the wound care. Well, what is the role of topical oxygen? So in this particular study, they had 132 patients who had venous ulcers for more than 2 years. These patients were enrolled. The average was 9 years Again, this is the reason why we hate treating these conditions. They divided those patients in half. So 60% of them were managed with cyclical pressure topical oxygen therapy, and 65 were just going to receive the conventional compression dressing. The endpoint was 12 weeks, and they were looking for reduction in ulcer size, time to heal, and what was the recurrence rate at 36 months. Here are the results. The mean reduction in ulcer surface at 12 weeks was 96%. That's huge on these patients that were managed with cyclical pressure topical oxygen. And 61% of the patients that were managed in just the compression therapy. So 96% is huge. At 12 weeks, 76% of the cyclical pressure topical oxygen managed patients had completely healed, 76%. And again, I've been doing this for 30 years. I've never had a venous stasis ulcer heal in 12 weeks. So using the compression therapy is important, but adding the cyclical pressure topical oxygen is essential. Well, what happened long term? After 36 months, 40% of the healed compression patients had a recurrence. Only 6% of the cyclical pressure topical oxygen patients had recurred. That's huge. And the reason that happened is because of the collagen. Again, very difficult condition to heal. In addition to that, the MRSA elimination in patients with cyclical pressure topical oxygen therapy was 46% compared to 0 in the patients who just got compression. So again, remembering that the topical oxygen assists in the antibiotics, assists the patient getting rid of the bacteria. So that's huge. So again, remembering compression is important. We always have to use compression in patients with chronic venous insufficiency. If we don't, we're hindering our patients. So we need to be able to use compression with our patients to long-term to make sure that they don't recur, because if we're not managing the venous insufficiency, we're not managing the edema, it doesn't matter if we have arterial pulse because there's no flow through the capillary beds. There's no flow through what we're seeing. So cyclical pressure topical oxygen can help us combat wound infections and treat our patients safely at home. This is really important during COVID. It's easy to do, it's safe, it doesn't have any of the systemic effects of hyperbaric oxygen. It doesn't require the patient to go to the center. It provides intermittent tissue hyperoxia that's going to upregulate the patient's immune function at the wound level. It's going to upregulate the VEGF, which is going to give you the neovascularization. It's going to increase collagen. It's going to make our antibiotics more effective. And it's shown to heal both diabetic foot and venous leg ulcers 6 times better at 12 weeks than anything that we've been doing without it. So it's going to stimulate not only the healing at 12 weeks, but it's the long term. There's a 6-fold reduction in diabetic foot ulcers and VLUs at 36 months because the quality of the healing, the quality is much better because of the collagen. So again, this is something that if you're not doing it with your wound patients, your diabetic wound patients and your VLU patients, that you want to incorporate that into your practice because you're missing the boat if you're not. And especially now because of COVID, these patients are scared. They're not going to your office. They're not going to the wound care center. These is something that we can work together with our home health companies and our vendors to get these cyclical pressure topical oxygen systems to our patients and get the outcomes that those patients deserve and that we're looking for. So in summary, under our current COVID precautions, which are expected to continue for the next year and a half, there's a high risk patients are at home. They're not coming in for treatment. So I want you to think about cyclical pressurized topical oxygen to provide the effective adjunct for your treatment. There have been groundbreaking studies that have shown and demonstrated the short and long-term healing efficacy in the diabetic foot ulcer and venous leg ulcers. Now is the time to achieve better outcome in your patients. We really need to work together and to use the technology to get the outcomes that our patients deserve and that we're looking for.